Topic today is parasomnias. We've got 2 hours of talking. I'm planning on a break in between. The first half is a little longer than the second half, and we've divided these up into non-REM parasomnias and REM parasomnias. And there's a little bit of overlap, in terms of the topics that we cover, in each subsection. But the second half should be a little bit quicker, so hopefully we can get everybody out before. I just want to mention, I think in the view that I've got now, I don't think I can see chat. So if there is an important chat message that comes up, if somebody just wants to let me know, that would be great. Okay. This is a breakdown of the relative contribution of each topic area on the boards. Parasomnia, as you can see, account for about 7% of the knowledge that you're theoretically responsible for. And there's a roughly even split between the non-REM parasomnias and the REM parasomnias, with less than 1% being accounted for by these sort of other parasomnias, unusual sleep-related behaviors. So it's a small but not completely insignificant proportion of the exam. 3, I think, quick pearls just to kind of bear in mind at the beginning and throughout all this talk and throughout your studying for the boards. First of all, maybe you guys have taken 1 or more boards, maybe not, for your home disciplines, but boards are designed fundamentally to separate the competent from the incompetent, not necessarily to distinguish the excellent from the very excellent. So I'm saying that to hopefully induce some sense of calm and that things are going to be okay. But you obviously have to study. Good news is, between Kingman and Dennis, and to a very limited extent myself, we've got people who are writing questions for the boards and for ABIM. So we try and keep things relevant. But anyway, 3, I think, relevant pearls that are important to keep an eye on. 1, I think it's helpful to know the sort of differential diagnosis from various sleep-related behaviors based on these kind of key elements. Is there amnesia to the event or not? The semiology, which, if you're not a neurologist, just what does the event look like, and what is the sort of tempo and time course of that? What is the age of the patient, the frequency of events, both in terms of, in a typical week, but also their cadence in one particular night. And then in some cases, their EEG characteristics, although most parasomnias are not going to, strictly speaking, require an EEG for diagnostic purposes. Secondly, remember the ICST criteria. They test on this. And some of the questions are kind of nitpicky. So there's, no great way to go about studying this aside from just memorizing it. You'll be familiar with what these things, look like clinically, and you'll develop a sixth sense about what it is. That's just clinical experience, but some degree of memorization is going to be required. And then number 3, recognize unique features. If there are PSG patterns that correspond to one parasomnia or sleep behavior or another, that's an important one to know about. Most parasomnias do not require a PSG for diagnosis. It can be helpful, but not required. There's one exception to that. And then recognize that there are some common treatments for many parasomnias if treatment is required. And most of those common treatments are behavioral, but there are some shared pharmacologic therapies as well. So definitions first. I'm not aware of one sort of official AASM or ABIM endorsed definition for parasomnia, but this is the closest thing that I've found to it, and I like this definition, which is an undesirable physical event or sensory experience that occurs surrounding sleep, entering into sleep, during sleep, or arousing from sleep. Conceptually, I think it's helpful to think about when in the sleep cycle these events are happening. And I've just marked out a couple of the sort of more common occurrences. When we are entering into sleep, and so in a drowsy or light sleep state in particular, that's when we tend to see our sleep-wake transitioning conditions. When we're in non-REM sleep, obviously we have non-REM parasomnias. When we're in REM sleep, we obviously have REM parasomnias. But then an important sort of differential to consider with weird behaviors that happen in and around sleep is, are these epileptic in nature or not? This is not a hard and fast rule, but in general, nocturnal seizures tend to be clustered at the onset of sleep and upon waking up from sleep. And the same is generally true of the density of epileptiform discharges. And without getting too much into this, because this is another lecture, the different types of seizures in epilepsy are going to present here. Your absence epilepsies, a lot of motor epilepsies, and other types of epilepsy symptoms are going to present as arousal phenomena at the end of the sleep cycle, particularly myoclonic epilepsies. So an important concept to understand is that parasomnias probably represent overlapping states of arousal. In other words, that there are overlapping or coexisting brain states of sleep and wakefulness, or perhaps a rapid transition between the two. Later on, actually, I think in our second hour, there's a slide that I'll share with you that suggests actually that it's probably differential brain areas in different stages, as opposed to rapid oscillation of the whole brain as a unit between sleep stages. In other words, certain parts of the brain are asleep electrographically, certain parts of the brain are awake electrographically. And when that happens, well, weird things can happen and we get parasomnias. And maybe obviously the sort of overlap between wake and non-REM gives you your non-REM parasomnias, disorders of arousal and confusional arousal, sleepwalking, sleep terrors, things of that nature. And then your REM parasomnias happen in this overlapping area there. Without getting too much into the weeds here, a question that comes up fairly frequently is, how are somewhat complicated behaviors able to be initiated and sustained during a state where most of the cerebral cortex is asleep? Differential sleep states of different brain areas is one explanation for that. But the other is that there are central pattern generators, motor and sensory central pattern generators present throughout the central nervous system, all the way from the cerebral cortex down to spinal motor neurons. And the types of movements that can be generated by these central pattern generators can be pretty complex, including sort of locomotor movement, breathing, obviously, chewing, swallowing, eye movements, all the way up to more integrative or complicated behaviors that sort of link multiple different aspects of these, such as eating, and then obviously coordinated life. So it doesn't take much neuronal activity to trigger one of these central pattern generators and elicit a fairly complicated phenotype of motor or sensory behavior. Okay, so this is sort of a diagnostic schema that we're going to continue referring to throughout the morning's lecture, and this breakdown is based on the ICSD-3 criteria. There were some important changes between ICSD-2 and ICSD-3 in terms of what's a parasomnia, what's not, what's normal behavior, etc. And obviously you're going to be tested on the more recent incarnations of that, but be aware that in literature and in certain older textbooks, things may still reflect the old diagnostic scheme, and I'll try and point that out where it's relevant. But In order, we're going to be talking about non-REM parasomnias, or sometimes known as disorders of arousal, listed here, which include the following conditions: confusion arousal, sleepwalking, sleep-related eating disorder, sleep terrors, and sexsomnia. Then in the second hour, we're going to be talking about REM parasomnias, which are REM behavior disorder, recurrent isolated sleep paralysis, and nightmare disorder. No longer listed as a REM parasomnia is cataphrenia, which alternatively, depending on which scheme you're looking at, is either classified as a flavor of sleep disordered breathing or potentially a normal variant. Personally, I tend to categorize it under the umbrella of sleep disordered breathing. That's not usually done. And we'll cover some other parasomnias as well in the first half. Important but sort of minor point, somniloquy, sleep talking is considered a normal variant. Very, very common, especially in kids. And unless there's something else going on with the sleep, doesn't really require any further intervention aside from just reassurance. Okay, so launching right into our non-REM parasomnias then, the disorders of arousal broadly by ICSD-3 require that you meet these 5 criteria. So you may not need to memorize these today, but at some point before the boards, these are worth memorizing. So 1, these are recurrent episodes of incomplete awakening from sleep. 2, they involve a lack of response or an inappropriate response to external cues, intervention, redirection, that kind of a thing. 3, there tends to be very limited dream imagery or no dream imagery, and this is in contrast to REM parasomnias, which often have very active and vivid imagery. And there's very commonly amnesia, either partial or complete amnesia to the event. And then it's not due to something else. It's hard to fully satisfy that last condition, and this is where the sleep study and obviously a good sleep history often comes in. But again, a recurring theme is that polysomnography is not going to be required for most of these parasomnias, although it can be helpful, especially when you're trying to rule out alternative etiologies. Predisposing factors, this is an evolving, this is an evolving topic, but just some things to be aware of. So first of all, family history of a non-REM parasomnia is strongly predictive of personal history of parasomnia. There's at least one HLA haplotype that appears to be associated with I want to say somnambulism. There are polymorphisms on the long arm of chromosome 20. Children with developmental delay tend to have a much higher than baseline incidence of parasomnias, as well as other sleep disorders and sleep movement disorders in particular. But then for anybody, kids and adults, a sleep-related movement disorder, especially restless leg syndrome, it is quite likely to predispose to sleep-related parasomnia. And precipitating factors that may or may not be apparent on PSG include, number 1, enhanced slow wave sleep, so somebody with a lot of N3 sleep, which kids have naturally, but somebody who is sleep deprived and in their recovery stage, right, is going to have a lot of N3, particularly in the first 1 to 2/3 of the sleep stage. So that tends to be a hotspot for parasomnias. Impaired cortical arousal, meaning you would arouse fully, you would wake up, but the arousal mechanism is for one reason or another impaired, and so you have a partial or incomplete arousal. So think sleep aids, Z drugs, that kind of thing. And then sleep fragmentation, probably for the simple fact that the more state transitions you have, the more likely it is that you're going to get differential sleep state expression among brain regions. So a general rule with any of these conditions is things that disrupt sleep can precipitate parasomnias. And these are all the usual suspects: sleep apnea, supersonic breathing, periodic limb movements, stress, things of that nature. The time course or behavioral semiology of these events can be helpful in terms of differentiating them, and in some cases is actually part of the definition. So 3 of the more common types of non-REM parasomnias are shown here: confusional arousal, somnambulism, and a sleep terror, which we'll talk more about in detail. And you can see here plotted along the x-axis, this mouse is really slow, sorry. Plotted along the x-axis here is the time of the event in minutes, up to 10 minutes, although most parasomnias aren't lasting anywhere near that long, or probably even half of that. And then plotted on the y-axis is the degree of motor or emotive agitation. So your confusional arousal typically is brief and self-limited, that it involves little, if any, motor activity aside from just waking up and maybe sitting up. If there is displacement from the environment, by definition, that is sleepwalking. And sleepwalking tends to be a little more prolonged in terms of its time course. Fundamentally, these are the same physiologic phenomenon. It's just one is lasting a little longer than the other and involves displacement. And then in the case of a sleep terror, these are typically brief. I think probably this line should end more like here as opposed to here, but they're characterized by abrupt onset of significant emotive distress and motor activity that then tapers off fairly gradually. But importantly, that distress is usually unresponsive or very minimally responsive to interventions, usually parental interventions to calm down the child. And then I suppose you could have some mixed episode involving characteristics of all 3, although these are very unusual. So long story short, what it looks like has a large role to play in what it is. And so the clinical history is really important.
Really quickly, between confusional arousal and sleepwalking, they make some sort of distance criteria, or is it like you go out of bed, that was no longer confusional arousal, that was probably sleepwalking,
right.
Doesn't matter.
Right. So the question was how much displacement from the bed is required for it to be sleepwalking, and a generally accepted rule is, if the foot's on the floor, it's somnambulism. But obviously, there's a big difference between wandering around in the bedroom.
My child falling out of bed, so I would know they got up and walked out of bed if they didn't come on the floor. So I'm like, oh,
right. Well, and so that's a really important point. So certainly as the clinician, we rarely witness these events, but parents and caregivers may, but often do not witness these events, and so we're getting sort of secondhand report after the fact. So it would be very common to have the parent of a child, for example, say, I found my kid sleeping on the floor, under her desk. That's an example. Or I found her sleeping, sort of tangled up in her blankets right next to her bed. In that case, did she fall out of bed? Did she climb out of bed? Was she sleepwalking around the room and didn't make it into bed? We don't know. Unless you have a camera or something, which I guess more families do. But similarly for patients, especially adult patients, especially those without a bed partner who's aware of what's going on, they are often not aware of the initial onset of that event. They're just aware of the termination. So they end up in the living room in the middle of the night, or they end up in the kitchen, preparing food in the case of sleep eating and certain forms of sleepwalking. So the history is important, but the full history may not be available. If you're lucky and you capture an event in the sleep lab, I mean, that's the holy grail, right? But that almost never happens.
Sleepwalkers, just real quick, I know you're talking about.
No problem.
Did they make it back to the bed? Like, how's the typical?
So yeah, so many sleepwalkers left to their own devices will have an arousal or an awakening not in their bed. But some will actually, particularly, certain flavors of sleep eating. They'll make it into the kitchen, go through the activity of preparing food. They may bring it back to bed, consume it there, and go back to sleep, and then wake up with crumbs and candy wrappers all over. But I would say more commonly than not, they're waking up at some point along that trajectory. Particularly if there's a parent or a bed partner, or a spouse involved who's catching them in the act, and either redirecting them, which you can often do with sort of garden variety sleepwalking in kids, or trying to wake them out of it. So getting into the nitty gritty then of the sort of specifics of these parasomnias. So the confusional arousal is characterized by an arousal progressing to sitting up in bed, usually, often associated with verbal confusion, kind of confused behavior, disorientation, particularly if there's external cues. They may respond sort of bizarrely or inappropriately, and I'll show you some videos. If you just happen to capture this, on video, some of these can just look like the person sitting up, opening their eyes, scanning the environment. They often look kind of puzzled and then going back to sleep. It can be as simple as that. If there's displacement from the bed, then we categorize that as sleepwalking. This is sort of just a graphical representation that's supposed to demonstrate that you have a sudden arousal out of slow wave sleep. You have the behavioral phenotype, which is the sort of disorientation, inappropriate behavioral response, and so on. Amnesia to the event, and then rapid resumption of sleep. And this may repeat a few times, but typically just once. Okay, video time. So this is an adult patient. He's asleep on the couch. And here we go.
Where is he?
That would be kind of a classic example of a simple confusional arousal. And so if we break it down, we don't witness the very onset of the event, but maybe it was the female character walking into the room that triggered this event. But you see sort of almost choreoathetoid, sort of non-purposeful hand and finger movements. Head movements, partial attempts at sitting up. She then, sort of verbally prompts him, and he responds seemingly, confused. Where is he? She asks who. He says the holes, whatever that means. She's confused by that response, and he sort of mumbles something. But then when she continues prompting him, come on, let's go to bed, just at the very end, we see a more complete arousal or awakening. Watch that one more time, and kind of now that you know those key anchor points, just watch for them again.
Where is he?
And he's up. Okay. Questions, comments about that? Anybody?
In the typical cycle, you can have that. Is there a trigger for the arousal, or is this just in a child, for example, it's happening in the middle of the night? Do they hear a cat? Do they hear a door slam.
Yeah. No, that's a great question. So the question, just to repeat, was, is there typically a trigger for the arousal, or is it spontaneous? And it can be either, especially in kids, typically developing kids with occasional but infrequent confusional arousals. Those often appear spontaneous and are very common, actually. Now, digging a little deeper, I mean, there might be some stimulus that you could identify in the environment if if your metrics are sensitive enough, rustling outside, or who knows. But most such events in kids, at least, are often spontaneous. But the older you go, and certainly the more frequent these become, the more likely it is that there is some kind of trigger. The same triggers we talked about before. Think about sleep apnea, limb movement disorder, something else disrupting sleep. Okay. It's sort of a blurry EEG example, but what this was supposed to show is was the kid with his little EEG cap on, and here's EEG. So he's in slow wave delta sleep here. Then he sort of sits up, brings his head to the midline, still in slow wave sleep, sits up a little bit more, still in delta sleep, kind of stretches his arms, still in delta sleep, repositions, and back to sleep. You happen to catch one of these during a PSG, it's very common that this is what it will look like. These can get a little bit tricky because if they're moving a lot, you're going to get a lot of EMG and movement artifact. But if it's a garden variety confusional arousal like this, you might get lucky and have some good EEG background. Non-REM parasomnias can happen out of N2 sleep as well, but they're more common out of slow wave sleep. Here's an example from an adult patient. Looks like this guy might be hospitalized. Actually, he's got skids on. It's a hospital bed. Who knows? But in his case, there's an event that's apparent right here with a lot of motor artifact. Looks like in this case, this was actually precipitated by an obstructive breathing event. And your text can be very helpful here, especially when you're trying to figure out what's going on. And in this case, the tech pointed out the patient was flapping his hands and quacking like a duck. And this was occurring out of, I want to say, N2 sleep, but again, clearly precipitated by a respiratory event. Okay, confusional arousals are basically universal in kids under 5 years of age, and tend to diminish in their frequency over time. Kids with developmental differences and cognitive impairment are more likely to have persistence of confusional arousals, but that's not a universal rule. But as much as 4% of adults may have confusional arousals with any regularity. So interestingly, in people who reported, these are adults who reported confusional arousals, half had anxiety during the day, 60% had depression, depressed mood, 22% actually were diagnosed with bipolar, and 13% had obstructive sleep apnea. So there's a little bit of a chicken or egg sort of problem with this. Are these conditions causative of confusional arousals? Probably to some degree. Or are they the result of sleep disruption from confusional arousals? Probably not, but I suppose in extreme cases there could be enough sleep disruption that would be the case. But taken together, what's important to get out of this, that anything that is disrupting your sleep or reducing sleep quality really in any sense can be a precipitating factor for a confusional arousal or any parasomnia. What do you do about it? Usually nothing. If there is an underlying trigger identified, if it's a secondary parasomnia that, is in the example of the guy who was quacking like a duck, you treat the OSA and then you reevaluate. But outside of those scenarios, and in the case of primary parasomnias or confusional arousals, it's rare that you need to do anything. You should protect your sleep as best you can, avoid sleep deprivation, follow a regular sleep-wake pattern, things that we're telling patients to do anyway. Limit your exposure to CNS depressants as best you can. As we mentioned, manage the comorbid sleep disorders. And then there's limited, but some evidence suggesting that tricyclic antidepressants may have a role in reducing these non-REM parasomnias. Now, I do have one or two pediatric patients with confusional arousals that I've actually treated pharmacologically for the sole reason that we had identified all precipitating factors to the best of our ability. And in both cases, these kids were, during the arousal, pulling on a feeding tube or a PICC line or something else that was sort of eminently dangerous to their health. And so in those cases, we did end up treating that and used clonazepam in both of those cases, but those are not common occurrences. Okay, so confusion arousal with displacement is somnambulism. So as you imagine, that is characterized by an arousal followed by confusion and disorientation, just like a confusion arousal, automatic behavior, just like a confusion arousal, and displacement from the bed. And this can, the degree of displacement can vary a lot and can end up being very complex. Sort of automatic, non-goal oriented behavior, wandering around the room, that kind of thing is pretty common. But again, navigating to the kitchen to turn on the stove, or finding your way into the bathroom, or the closet and peeing in the closet, for example. We've heard about that before. So, and then in very rare cases, you may have kind of agitated, inappropriate, even violent behaviors. And in those cases, there's actually a medical legal sort of element to it. We'll get into some specific details later, but if it's not all that uncommon that some behavior in the middle of the night is blamed on a parasomnia. That comes up occasionally in criminal defense. And in that case, you, as if you're the treating sleep person for that patient, your sense of whether that's true or not is helpful from a legal standpoint, but very challenging, as most medical legal issues are. And there are some resources that I'll present to you guys if you do ever end up in one of those cases. So, okay. Sleepwalking is fairly common in kids. Maybe a fifth or so of kids will have some degree of sleepwalking with any regularity. The peak age is between 4 and 8. Again, less common in adults, but somewhere up to 4 or 5% may have sleepwalking with regularity. But the lifetime prevalence is about a third, so it's quite common. Usually these are short, a couple of minutes, but they can last longer than that. And then again, they may involve sort of complex behaviors. And there are certain subtypes of somnambulism that are sort of separately classified as their own non-REM parasomnia. And those are sleep-related eating disorder, which we'll talk about, sexsomnia. Again, it's very rare that things like homicidal somnambulism will happen, but they have been reported before. I've never seen a case, and I hope I never do. Okay. So another example here, patient is in delta sleep. We see the arousal here, which occurred spontaneously. This sort of slow alpha activity frontally, and admixed against lower frequencies in other head regions, and then they're walking around. Okay, another video. So this is a middle-aged guy with a history of sleepwalking, and during this event, he described there was a truck swooping down on him, and it was confirmed that the arousal occurred out of N3 sleep. Okay, back to bed. So this one's kind of tricky. So most non-REM parasomnias don't have that sort of explosive onset. They obviously can, but most don't. And as we'll talk about later on in the lecture, we're sort of conditioned to think of, these defensive behaviors and psychomotor agitation is more of a REM parasomnia kind of thing. And that's true. With RBD, it does tend to be reflexive, sort of self-defensive behaviors, in rare cases, aggressive behaviors. But the same thing can happen in non-REM parasomnia. So
even though it's not typical to have vivid dream imagery, which in this case,
there was, yeah. So the question is, this is a non-REM parasomnia, and yet the patient was reporting some degree of dream imagery. So that can happen. I mean, we have dream content in non-REM sleep. It's qualitatively different, but it does exist. And so here it gets a little bit squishy, but typically, patients may describe sort of vague images or, a sense of, something was coming to get me, that kind of thing, as opposed to with your REM parasomnias, when the imagery usually is quite vivid.
So in this case, in a clinic setting, if the patient was describing, we would think more of a REM parasomnia versus a sleep study.
Probably so, yeah. So I mean, in this case, the history of sleepwalking is elucidative, so that would start to point you in the direction of a non-REM parasomnia. But if the primary complaint was, the patient or a bed partner saying, he leaps out of bed and starts, swinging at things in the middle of the night, my mind would probably go to RBD first and non-REM parasomnia second, but I would be wrong in that case. And so that's, that's where a PSG can be helpful. This is sort of a soft sign, I suppose, but RBD, the motor behaviors in RBD tend to be a little more sustained. So psychomotor agitation in a non-REM parasomnia, except for sleep terror, tends to be very brief. The arousal itself can be, a minute, 30 seconds, however long this was. But the motor agitation lasts, what was that, 2 seconds, 3 seconds, as opposed to RBD, and we'll see some videos of this later, where it's usually much more sustained, more kind of goal-directed. I'm hitting something, I'm smacking something, I'm defending myself, as opposed to this quick sort of leap, and then it's done. Again, it's hard to codify that, so that's just sort of a soft diagnostic sign, but in general, that is true as a differentiator between the two. Okay. This next patient is a young woman who has a history of recurrent sleepwalking. During this event, she also reported vague dream material after the episode, and was also confirmed to have an arousal coming out of slow wave sleep. So this is still part of the confusion arousal. She's not awake here. But you notice the agitated behavior lasted a couple of seconds at most. Probably still in the arousal at this point, and then now the tech or doctor, whoever comes in, now she's awake. Okay.
What was it about the case that made it somnambulism rather than?
Right. So this, yeah, so the question was, why is this somnambulism and not a confusional arousal? And the answer is, this is not somnambulism, but the patient has a history of recurrent sleepwalking. So Again, really the only difference is, does she get out of bed or not? But the fundamental physiology is the same. Okay. Any other questions about that? All right. Treatment. Environmental safety really is the mainstay. And tailor it to the individual patient. So patients with a history of falling or at risk of falling, make sure that sharp objects are kind of covered in the bedroom, especially with kids. Patients who have walked long distances, make sure there are difficult locks on exterior doors. Padlocks with a key kind of hidden somewhere, combination locks that are, high and out of easy reach tend to be good options. Your standard door lock usually doesn't cut it. Should go without saying, lock up guns and knives, guns especially, but even, kitchen knives, if there is a history of sleepwalking, I will usually say, put those in a drawer and make sure it's locked. Somebody who's making their way into the kitchen, turning on the stove, either if you have, a flat top, put it in locked mode or take the dials off the stove, that kind of a thing. Sleep in a downstairs bedroom if there's a concern about falling down the stairs, put baby gates at the top of stairs, that kind of thing. Scheduled waking, especially in kids, can be helpful. This is true of any type of parasomnia. But if they tend to occur, if the parasomnia events tend to occur within a relatively predictable time frame, then rousing the child a few minutes before then can be helpful to sort of avert the event. Same is true of nocturnal uresis, by the way. That's harder with adults, and especially people who are sleeping on their own. You can set an alarm, but no guarantee that's going to work for you. There's some evidence for psychotherapy or hypnosis for frequent somnambulism. That's never something that I've recommended personally. You want to avoid precipitating factors again, treat any underlying sleep disorders, obviously. You want to avoid medications that can precipitate sleepwalking. The Z drugs are probably the prototypical example of meds that can exacerbate sleepwalking. And then in some cases, you can consider treatment confusingly with benzos. So if anyone knows better than I do, I'm certainly interested in hearing your understanding of this, but I have never heard a convincing explanation of why a non-benzo benzodiazepine receptor agonist would cause sleepwalking, whereas a benzodiazepine wouldn't. They're both binding to, they're both sort of precipitating GABA A activity. Zolpidem and Z drugs are specific, GABA A alpha 1 binders. They don't have any, gamma activity, which a benzo would. But again, aside from that small binding difference, I'm not aware of a reason why there would be such. Exactly. Yeah, exactly. Nonetheless, there is some, reasonably good evidence that, benzodiazepines, and I've listed a few in typical dose ranges up here, can be used. And there's very limited evidence for, TCAs and SSRIs and melatonin. Emphasis on very limited. Sexsomnia, probably more common than we think, but maybe for obvious reasons, patients don't often volunteer this kind of thing. But this is a flavor of confusional arousal or non-REM parasomnia characterized by sexual behavior that can be oriented towards the patient themselves, their bed partner, a bystander. And importantly, this is usually out of character to their usual sexual behavior, not always, but often. These can look all kinds of different ways. Most people with, who report sexsomnia do have a personal or a family history of sleepwalking. Again, you're not required to do polysomnography, but almost always you are going to do that to rule out precipitating factors, especially sleep-disordered breathing. As I mentioned, this does potentially have legal ramifications, particularly if it's a bystander, but even if it's their typical bed partner. Without getting too far into the weeds of, the legal aspects of sleep medicine, the MacArthur Foundation Research Network website has some really helpful information for physicians about how one might navigate cases like this, including case examples and how-tos and so on. Some people, make a career out of being expert witnesses, and one of my mentors in fellowship was a sexsomnia expert and had testified in multiple cases and written some chapters and so on treatment, and she would usually use benzos, but this is not a common occurrence, but important enough to be aware of, and perhaps consider integrating into questionnaires and things. If we don't ask, it's almost never volunteered. If we do ask, that increases the chances that we're going to hear about it. Chat. Oh, okay. Bye, Eric. See ya. All righty. Okay, treatment again, as with everything else, optimize sleep hygiene, address underlying factors, manage anxiety and stress. Counseling is particularly important in sexsomnias. There is often, but not always, some history of an issue. I won't say trauma, although that's one potential issue. That needs to be addressed carefully and professionally by an expert. And again, there's some evidence for the use of benzodiazepines in the treatment of really problematic and recurrent sexsomnias. There's a couple of good chapters on the medical legal implications of sleep medicine in Krieger's big review book. It's probably the best compilation I've seen so far, so it's worth a read. Okay, sleep terrors, you'll definitely hear about these. Fairly common in kids, very rare in adults, but has kind of a classic semiology. Once you see it, you're never going to forget it. If you have kids and they've had a sleep terror, you're definitely not going to forget it because they're terrifying, but they're largely benign. So sleep terrors are characterized by extreme sort of psychomotor agitation with a very abrupt onset, usually involving a scream. There's increased sympathetic response, sometimes aggression, but more commonly sort of resistance to outside intervention. So this is one parasomnia where attempts to kind of calm the child down and redirect them are usually counterproductive. This is another EEG example here. So out of slow wave sleep, there's the sudden onset of psychomotor agitation, and you can see that kid just starting to scream there. Up to 6% of kids will have a sleep terror at one point or another. 1% or fewer of adults will have sleep terrors. If you happen to capture this on a PSG, again, typically you're going to see an arousal from stable N3 followed by sympathetic hyperactivation. Your heart rate's going to go up, motor activity is going up, muscle tone's going up. Treatment for these, usually reassurance, but certainly you want to ensure environmental safety, good sleep hygiene, that kind of a thing. Scheduled awakenings can be helpful if the sleep terrors are very frequent and predictable. I have never treated a sleep terror before, but there is some evidence out there, again, for low-dose benzos. Usually reassurance is the mainstay of treatment. And specifically, that means, if you're the parent of a child with sleep terrors, go into the bedroom, calm reassurance, but expect and understand that your child is not going to respond to you, is probably going to keep screaming. If you try and shake them to wake them up, that's probably going to deepen the confusion and motor activity. So we typically advise folks to just wait it out, which is hard to do.
How long do you say?
Hmm?
Typically 5 or 5 minutes.
Under 5 minutes. So 1 to 2 minutes would be the mode. Okay. Sleep terrors versus nightmares is a kind of pediatrics 101, but important to know from a sleep standpoint as well. Sleep terrors are a non-REM phenomenon. Nightmares are a REM phenomenon. So the timing, movements, and other characteristics sort of fall into place based on that distinction. Sleep terrors tend to happen in the first half, really first third of the night, where there's a lot of and 3. Nightmares tend to happen more commonly in the last third of the night, where you've got more and more dense REM. Obviously, you can have a nightmare earlier in the night, but the greatest frequency is in the last half. Movements are common in a sleep terror, rare in nightmares. Vocalization are common in sleep terrors, rare in nightmares. The autonomic tone increase is usually quite intense in sleep terrors and sort of mild to moderately elevated in nightmares. Amnesia is almost always present in sleep terrors, and that's a good thing. And whereas most nightmares are remembered, at least immediately after. The state upon awakening after sleep terror is typically confused and disoriented, whereas after a nightmare, most people are pretty functional, at least close to baseline. Injury is rare with nightmares. I wouldn't say common with sleep terrors, but more common than nightmares. Violence, take that with a grain of salt. Let's say psychomotor agitated behavior, common with sleep terrors, rare with nightmares. And displacement is very rare with nightmares. Okay, moving on to other parasomnias, and we're at the 9 o'clock hour, so after this we'll take a break. Sleep-related eating disorder. This is a parasomnia. There are other eating disorders that happen around sleep that are not parasomnias. And it's important and helpful to distinguish between the two. Sleep-related eating disorder, or SHRED, is described as preparation and consumption of edible as well as non-edible substances while asleep. My favorite example of this is a patient of mine who was eating all kinds of things, but what really jarred her and brought her to medical attention was she was smearing peanut butter on a carton of cigarettes, and woke up when she bit into it, and yeah, gross. It's memorable for sure. So you will very often see that the types of things prepared and consumed during a SHRED episode are unusual. They're never fixing a salad in the middle of the night. It's almost always very high calorie, calorie dense food, and maybe very bizarre. Peanut butter on a cigarette carton as an example. It's important to differentiate SHRED from evening hyperaphasia and night eating syndrome. Neither of these are parasomnias. Evening hyperaphasia is excessive eating after the last meal, but before falling asleep. So this is not middle of the night eating. If someone consumes more than half of their daily calories in the late evening before falling asleep, or in the middle of the night during a full awakening, that's night eating syndrome. These are generally considered to be somewhat rare, but are certainly more common in the eating disorder population. And where we see most of these is in our bariatric surgery patients, pre-op. Again, less than 5% prevalence in the general population, but up to about 15–16% in patients with eating disorders. If you happen to capture one of these events during the PSG, the sort of pathognomonic finding is rhythmic masticatory motor activity, or MMA. I'll show you an example of that. Treatment for this, again, it's environmental safety and prevention. Lock up the food, remove the knobs from the stove, that kind of a thing. Treat underlying sleep disorders. You guys are noticing a theme here. This is true for all of these conditions, especially RLS. There's a strong association between RLS and SHRED. And then there's some evidence for a variety of medications. I will usually go with topiramate. Often these patients are already on topiramate for weight loss and appetite control purposes, but we've got other options here. Okay, here's a blurry example of rhythmic masturbatory motor activity. This is a patient who's snacking on something, and that's not unusual in the sleep lab. You'll see people eating all the time, but the issue is he's eating in and to sleep. So very hard to tell here because it's all obscured by motor artifact. But you would see a lot of sort of rhythmic EMG movements there, as well as EEG artifact. But before and after, the background should show sleep. Patient is eating popcorn. Okay. We're closing in on the end of the lecture here now. So other parasomnias, rare, but I feel like they always test on exploding head syndrome, and it's an important enough one to know about. So exploding head syndrome is characterized by sudden onset of usually a sense of a loud noise, popping, snapping, exploding, usually upon awakening. That can happen when falling asleep. There's an abrupt arousal following that. And importantly, there's no pain. They may perceive the initial event as painful, but the pain does not persist beyond that initial event. This is reportedly rare, but probably more common than we think. People have hypothesize that this may be a flavor of a hypnic auditory hallucination. I don't know how you prove that, but it's certainly possible. Most of the time, your treatment is going to involve reassurance. There have been, very limited data conducted on, these medications listed here. Typically, I will not treat these, or if I do, I'll go with topiramate. That have some benefits on other flavors of headaches as well, so why not? But again, usually reassurance is the treatment. Okay, sleeping uresis. This has to happen older than 5 years. Children under the age of 5, unless they happen to be otherwise potty trained, typically are not pathologized if they have sleeping uresis. This is characterized by recurrent involuntary voiding during sleep at least twice a week. It's got to be present for at least 3 months. And you'll often hear it categorized as primary or secondary. Primary meaning the patient has never been consistently dry at night. Secondary meaning the patient had been consistently dry for at least 6 months and then had onset of the uresis. Fluid restriction, bedwetting alarms, DDAVP in certain cases, and if there is any underlying health abnormality, sleep disorder, renal abnormality, urologic abnormality, you obviously want to treat that. Much of the time, you're certainly going to hear about this in pediatric sleep clinic. Much of the time, the pediatrician will have dealt with this, or at least tried to, and there's not a whole ton more that we can offer for this, aside from a complete sleep health assessment. But sometimes the pediatrician hasn't had a chance to deal with this, or in certain cases it can happen in older kids. I have a 16-year-old who came to see me last week for sleep-related enuresis, and almost certainly has OSA as well. But the older you get, the more likely it is that there's a secondary cause. Okay, a couple of questions and then we'll take a break. So number one, this family of a 5-year-old boy who's presenting to clinic describes an episode of inconsolable crying and screaming occurring once or twice per week, usually within 2 hours of falling asleep. He returns to sleep within a few minutes. When questioned in the morning, he does not recall the events. Which of the following is true regarding these events? Important note, this is not a 5-year-old. All right, so A, B, C, or D. And I'm going to minimize this here just so I can look at the Zoom here. Okay, so I'm going to be mean, and so I'm going to ask Fessel to answer this one, Zach to answer the next one, Netta if you want to do the third one, and then the fourth one will be a free-for-all. Okay, so what do you think for this one?
So 2 hours.
So first of all, do you think this sounds more like a non-REM or a REM parasomnia?
Seems like a non-REM.
Yep, agreed.
So, does not recall it.
Yep, amnesia within the first couple hours as opposed to the last few hours. So again, not pathognomonic, but strongly suggestive of non-REM parasomnia. Okay, I agree. Which non-REM parasomnia does this sound like? Inconsolable crying and screaming.
Kind of like
Night terrors, yeah, exactly. Okay, I agree with that too.
That part, no, I'm just thinking which is the right answer. I'll go with C.
Okay, good. So, so this is a really important point. So, must is the operative word there. Yeah. So, if this said they may be evaluated by polysomnography, that would be 100% correct, and this would be a kind of a bad question. But based just on this semiology, if you take a good sleep history and the patient is otherwise healthy, this sounds like a pretty classic sleep terror, and you could well just reassure the family. So yeah, so A is false, right? Because we said it's a non-REM parasomnia. B is supposed to be the correct answer. They could be treated with scheduled awakenings.
I guess the only reason I'm thinking against that is because if it occurs within 2 hours,
yeah,
schedule an awakening with them. But I guess
right,
theoretically it makes sense.
Theoretically, you could, yeah. So I wouldn't schedule an awakening half an hour after they woke up, but an hour and a half after you could.
What happens if, why doesn't that just reset the clock?
That's a great question. Yeah.
Just get another half hour.
Yeah, so especially if they go right back into non-REM sleep, especially slow wave sleep, why does that work? Well, the answer is sometimes it doesn't. So scheduled wakings have the best evidence in uresis, where you can wake the kid up, get them to void, and then the bladder's empty, and then get them back to bed. Certainly if the full bladder is triggering the arousal, that can help. The likelihood that it's going to be successful decreases a bit if you're talking about other non-REM parasomnias, but it still can be helpful. And the mechanism for that is not clear to me.
So also for nocturnal enuresis, is it so the age cutoff is 5, but what is the cutoff for when it's considered still normal?
Yeah. So technically speaking, if the child is so on the boards anyway, if you have a 3-year-old who's working on potty training and is dry most of the day, but still wetting the bed, you would probably consider that normal. In my own practice, I would say if they are consistently dry during the day and have been for 6 months, then I'll start looking into, could this be a secondary enuresis, even if they're under 5. But the textbook answer is under 5, always normal.
But even over 5, because certain, like I remember reading this, I remember even our pediatrician told us that for children like up to 7 years,
it can be normal. Yeah, it can be normal. So above 5, you could rightly classify it as pathological nocturnal enuresis. It's still very likely to resolve. It still may not have anything to do with an underlying sleep disorder, but your index of suspicion is going to start to increase after that. And after about 8 or 9, the prevalence is really very low. C, we talked about, and then D, they may be an early marker for narcolepsy. No, there are certain parasomnias that can be seen in people with narcolepsy. Mostly those are REM parasomnias, and we'll talk about that in the subsequent hour, less than an hour. Okay, was this Zach's question? Okay, 19-year-old woman presents to clinic following reports by her roommate that she routinely consumes her cat's food at night, and she also eats large quantities of peanut butter. Patient does not recall doing so, but has noticed a 20-pound weight gain in recent months despite attempts to diet. What is the most likely explanation? C, yeah. So this is shred. So it's not Klein-Levin syndrome, which is a very rare recurrent hypersomnia. It's not a confusional arousal because by definition she's getting out of bed, so it's at least sleepwalking. It is sleep-related eating because she has no recollection, presumably she's asleep. It's not night eating syndrome because you would remember night eating syndrome, you have to be awake. But one would hope, yeah. And this unintentional weight gain, despite attempts to not gain weight, is actually fairly common. Okay, Ned, I think this is your question here. 52-year-old guy presents with bothersome nocturnal spells in the beginning of the night associated with fear. We get a PSG. They occur during transition to N1 sleep, at which point he wakes up, holds his head, and yells that his head is snapping. Which of the following is the most likely diagnosis?
So there is no headache, it's just that snapping. So
we can't hear her.
Okay, and I don't know if you're talking. If so, I apologize. We can't hear you. If that's the case, you're welcome to put it in chat. Yep, seems like there's no headache. Yep, agreed. D, yep, exactly. Yeah, so that's the sort of key with exploding head syndrome, is it really isn't associated with pain. Discomfort around the sensation, absolutely yes. And you can have migraines surrounding bedtime. You can have a hypnic headache, going to bed or waking up. I mean, you could have a cluster headache that's not common to happen around bedtime, but exploding head syndrome is the right answer. I agree. Fun fact, bedtime caffeine can actually be helpful in hypnic headaches. I've only prescribed it once and it didn't work. But I tried. That's why you don't have a hip. Yeah. All right.
Is it rhythmic? Like this seems to describe continuous snapping. Maybe
That's a good point. Yeah. So it's not this, it's this. Yeah. Should probably reword that so it's clear. But yeah, it's not a recurrent thing. Okay, this is a free-for-all. 42-year-old woman presents to clinic after an episode during which she awoke to find herself standing on her front lawn with the sprinklers on. She has a history of sleepwalking as a child. She wonders if a new medication that she started could be responsible. Which of the following is the most likely offending agent? B. Yeah, I agree. Clonazepam is in there to kind of trick you up. Benadryl, any sedating medication could precipitate, parasomnias, but it's far less likely than a Z drug. And hydralazine is in there just because. Okay. Yeah. Right, exactly. All righty. Okay, so that's